Moving on, today's topic is related to eclampsia. Eclampsia is a severe complication of pre-eclampsia. It is rare but serious condition where the high blood pressure results in seizures during pregnancy. Now let's see the definition and meaning of eclampsia. The term eclampsia is derived from a Greek word. It is a Greek word which means like a flash of lightning. So preeclampsia, when complicated with convulsion or coma, is called eclampsia. In the last class we discussed regarding the preeclampsia. So when the preeclampsia symptoms comes along with the convulsion or fits, it is known as eclampsia. Moving to the causes of eclampsia, the main cause is the cerebral irritation which can lead to convulsion, but the cause of cerebral irritation is not clear. Usually this irritation can be provoked by certain factors like anoxia. So anoxia can occur because of the spasm of cerebral vessels due to the high blood pressure. So as the blood pressure increases, there will be spasm of cerebral blood vessels which results in increased cerebrovascular resistance. There will be resistance in the blood flow in the cerebral vessels which can cause a fall in cerebral oxygen consumption. There will be a fall of oxygen consumption in the cerebral tissue and finally results in anoxia. So this anoxia can also be a cause of cerebral irritation. The next factor is cerebral edema due to the high blood pressure, and due to cerebral edema or anoxia, it can finally result in cerebral dysarrhythmias. So these are some of the risk factors or some of the causes which can result in cerebral irritations and cause the convulsion. Let's see the onset of fits. Usually the fits occur most commonly in the third trimester. More than 50% of cases, the fits can occur in the third trimester time. On rare occasion, it can occur even in the first trimester, like in the first 3 months if the mother having the problem of hydatiform. Fits occurs during intrapartum is 30%. That is, in 30% of mothers, this fit can even occur during the time of labor or delivery. And 20% of cases, it can occur in the postpartum period also. Coming to the clinical features, it is mainly divided into 4 stages. The first stage is pre-monitory stage. So in this stage, you can see the patient become unconscious, the mother become totally unconscious. There is twitching of muscles, there will be in the face, tongue and limbs. So it starts, the twitching of muscles starts from the face, tongue and even to the lower extremities. Then the eyeball will be turned to one side, it become more fixed, and the stage will last for about 30 seconds. So this stage is known as premonitory stage. The second stage is the tonic stage, where the whole body goes into tonic spasm. You can see the body in a spasmic stage. The trunk becomes opistonous. Opistonous is a condition where the spasm of muscles causing backward arching of the head, neck and the spine. So the body will be in an arc-like posture. So that is known as opistonous. The limbs become flexed. The hands will be in a clenched position. There is a chances of ceasing of respiration due to this tonic spasm of muscles. The tongue protrudes between the teeth. The cyanosis will appear as the respiration ceases. The eyeball become more fixed and the stage lasts for 30 seconds. These all symptoms is same like when the patient is in a fit stage. Next is the clonic stage, where all voluntary muscles undergo alternating contraction and relaxation. The twitching starts from the face and then involve one side of the extremities. Ultimately, the whole body undergoes the alternating contraction and relaxation. There can be the meeting of tongues which can cause blood strained frothy secretions comes out from the mouth and the breathing becomes very difficult because the patient starts breathing in a difficult manner. The cyanosis gradually disappears, and this chronic stage lasts for about 1 to 4 minutes. The last stage is the stage of coma. Following fit, the patient passes to a coma stage, and it may last for a brief period, or in other deep coma persists till another convulsion comes. The patient appears to be very confused and fail to remember what happened recently. But in rare condition, this coma occurs without any prior convulsion also. So these are the 4 stages that you can see in a eclampsia. Moving to the complications of eclampsia, first there is chances of injuries due to tongue bite, injuries due to fall from a bird, then pulmonary complications can occur like edema, pneumonia due to the aspiration of fluid, or embolism can even occur, then hyperpyrexia due to the overstretching and relaxation of muscles, cardiac failure, renal failure, hepatic necrosis, cerebral edema, disturbed sleep. These are some of the complications that can be seen in the mother. Next is the complication that can occur after the delivery, that is during the postpartum period. The chances for shock, sepsis, and even psychosis for mother. Next is the causes of maternal death. If the eclampsia is not controlled properly, or we are not able to manage the increased blood pressure level, there is more chances of cardiac failure, pulmonary edema, aspiration of fluid, anuria due to chronic renal failure, pulmonary embolism, postpartum shock, and puerperal sepsis. This all can result to the maternal death. The causes of fetal mortality is mainly due to the prematurity. If in some condition, if you are not able to control the BP, the doctors will be forced to conduct the delivery without seeing the gestation. In that time, the baby may be in premature also. So it can result the fetal mortality, and sometimes the intrauterine asphyxia can occur due to the increased blood pressure, which results in the placental insufficiency, and so that there will be the less amount of oxygen will reach to the baby and results in intrauterine asphyxia. So these factors also cause the fetal mortality rate. Moving to the management, the first aid and treatment outside the hospital is the first thing we can do. In that, the urgent shifting of patient to the tertiary hospital. If you are living in a village or a slum area, it is very necessary to shift the patient to the tertiary hospital, where the mother will get a proper treatment. The patient must be heavily sedated before moving to the hospitals. So in giving sedation, we can give the drugs like Largitide 50 mg IM and Finagan 25 mg, or Diazepam 10 mg IV can also be given to sedate the mother. Next is the obstetric flying squad or trained midwife should be accompany the patient always while shifting to a tertiary hospital to manage any emergency situation. She should be equipped to prevent the injury or clear the air passage if fits occurs. So in the ambulance should be well equipped to prevent any kind of injury or to clear the fluids while if the fit comes. And next is the management once the patient reaches the hospital, and there are some principles that we need to follow. The first is resuscitate the mother and maintain the airway. Provide the oxygen administration, arrest the convulsion if she having the fits, provide enough ventilatory support, try to control the BP if it is elevated, then organize the investigation, both blood and the urine examination, try to deliver the mother within 6 to 8 hours to save the baby as well as the mother, and provide intensive postpartum care to mother and baby after the delivery. Now let's see the general management. The patient should be placed in the rail cot to prevent any kind of fall from the bed. She should have a doctor or at least a midwife for the constant supervision of the mother, and a detailed history should be taken from the relatives, include the pregnancy, the duration of pregnancy, the number of fits, the nature of medication they have given before transferring the mother to a tertiary hospital. If the patient is unconscious, self-retaining catheter is mainly introduced to test the protein of 24-hour, and a continuous drainage facilities measurement of the urine output should be maintained, and half-hourly pulse, respiration, BP should be recorded. Next is the fluid balance. So vinegar lactate solution is the first choice of treatment. The total fluid should not exceed the previous 24 hours urine output plus 1000 ml. So it should not exceed 24 hours urine output plus 1000 ml. Normally it should not be more than 2 liters in 24 hours. Along with that, we need to measure the central venous pressure in case of severe hypertensive mothers. And in antibiotics, usually we are preferring to give ampicillin 500 mg IM or IV 6 hourly to prevent any kind of infection. Coming to the specific management, in that the first is anticonvulsant and sedative regime. The main aim is to control the fits and prevent the recurrence of fits. So for this treatment, mainly we are giving the magnesium sulfate. It reduces the neuromuscular irritability. So reduce any kind of cerebral irritability which can result in the fits. It induces cerebral vasodilation so that there will be a good blood supply, dilates the uterine arteries so there will be sufficient oxygen moves to the baby, and inhibits the placental activation. And the main thing is it doesn't have any determinant effect on the neonate within the therapeutic level. Coming to the regimen of magnesium sulfate, it can be given as intramuscular and intravenously also. So in IM case, the loading dose first 4 gram IV over 3 minutes is given, followed by 10 gram deep IM, that is 5 gram in each buttocks, that is the loading dose. In maintenance dose, 5 gram IM 4 hourly in alternate buttocks. And if intravenously we are giving the loading doses 4 to 6 gram IV over 15 to 20 minutes of duration, and the maintenance dose is 1 to 2 gram per hour IV. Repeated injections are only given if the knee jerks are present and the urine output exceeds 30 ml per hour and the respiration is more than 12 per minute. The therapeutic level of the magnesium is 4 to 7 MEq per liter. If the level is more than 7 MEq, it can affect the baby. The baby will get adverse effects. So always maintain the therapeutic level. The magnesium sulfate is continued for 24 hours after the last seizures. For recurrent fit cases, further 2 gram IV bolus is given 5 minutes. Next is the lytic cocktail regime, which is very important for managing the eclampsia. The drugs mainly used are chlorpromazine, phenergan, and pethidine. A combination of these drugs are used in lytic cocktail regime. It is mainly for reduction of maternal mortality rate to 2.2%. So on admission, so these three drugs in a combination are given. First 25 mg chlorpromazine plus 100 mg pethidine in 20 ml of 5% dextrose IV, along with 50 mg chlorpromazine plus 25 mg promethazine IM is given. Subsequently, promethazine 25 mg and chlorpromazine 50 mg IM alternately at 4 hours interval for 24 hours following the last fit. Then IV 500 ml of 10% dextrose drip is started at the beginning with 100 mg pethidine at the rate of 20 to 30 drops per minute. But you need to remember that not more than 2 liters of dextrose and in all 300 mg pethidine are to be given in 24 hours time. The pethidine drip should be continued up to 24 hours following the last fit to maintain the sedation of mother. Next drug is the diazepam, which is given in an initial dose of 40 mg as IV. Further 40 mg in 500 ml of 5% dextrose is infused at 30 drops per minute or adjusted according to the need of mother. The next drug of choice is phenytoin, mainly used to control the convulsions. It is given very slow IV because it can cause variation in the ECG. So there will be ECG monitoring while giving the phenytoin therapy. The initial dose is 10 mg per kg followed by 5 mg per kg 2 hours later. Thereafter 200 mg is given orally after 12 hours and it continues until 48 hours after the delivery to prevent any kind of further convulsions. The important side effects of phenytoin therapy is hypotension, cardiac dysarrhythmias and phlebitis. Next are the antihypertensives and diuretics which are given when the BP is more than 160 by 110. So the commonly used antihypertensive drugs are hydrolazine, levotilol, calcium channel blockers and nitroglycerin. And in case of pulmonary edema, the Lasix is the drug that is given for diuresis. The dose is 20 to 40 mg IV. Coming to the management during fits, in the pre-monitory stage, mouth gag is placed, then remove after the colonic phase. The air passage is cleared to prevent the aspiration of fluid. The mouth gag is placed to prevent the wetting of tongue. The head is turned to one side to prevent the aspiration of fluid and which results in pneumonia. And the oxygen administration should be given to prevent the cyanosis. So in status epilepticus, thiopentone sodium 0.5 gram dissolved in 20 ml 5% dextrose is given. The procedure should be supervised by the expert anesthetist. For the treatment of any kind of infection, the prophylactic use of antibiotics are given. And in case of pulmonary edema, fusimab, that is Lasix, 40 mg IV, followed by 20 gram of mannitol IV to reduce the cerebral edema is given. Then pulse oximeter to monitor the oxygen level. The aspiration of mucus from the tracheobronchial tree to prevent the pneumonia. And in case of heart failure, the oxygen inhalation along with parenteral Lasix need to be provided. In anuria, the urine output returns to normal following by the termination of pregnancy in most of the cases. In case of hypopyrexia, the pulse punching and antipyretics are given. And if the mother having the problems of psychosis, chlorpromazine need to be started. The last is the intensive care monitoring for that the mother can be admitted in the ICU where she will get a proper treatment from a team of members. Now let's see the obstetric management during pregnancy. If the fix is controlled and the baby is mature, the termination can be done. And if the cervix is favorable, you can do the surgical induction, that is ARM can be done along with the oxytocin to progress the labor. And if the cervix is not favorable, we need to do the cervical ripening by giving the prostaglandins, then do the ARM along with the oxytocin. And if the cervix is unfavorable and contraindicated, then only choice is the cesarean delivery. And in case if the baby is premature, continue the pregnancy along with the treatment for mother. There should be a frequent fetal well-being monitoring, and when sufficiently mature, the termination can be done. If the baby is dead, the pre-eclamptic process gradually subsides, all the symptoms will be start disappearing in mother and eventually there will be the expulsion of the baby. In case if the fit is not controlled with the anticonvulsants, the termination is the only choice and you need to do the PV to see the cervix condition. If the cervix is favorable, you can do the ARM along with the oxytocin infusion to terminate the pregnancy. And if the cervix is unfavorable, you need to take the mother immediately for the cesarean section to save the baby and the mother. Next is the management during the labor. In absence of any contraindications, the mother can be taken for normal vaginal delivery, and LRM, that means low rupture membranes, can be done to accelerate the labor. Scheduled antihypertensive plus anticonvulsant drugs should be increased during the labor also. And even the second stage of labor can be reduced by the applications of forceps and venous delivery. And if the baby is dead, craniotomy is usually performed to expel the baby, but the staff member should be very vigilant about the postpartum hemorrhage during the labor also. In some cases, we need to take for the CS like uncontrolled fits, unconscious patient, and case of obstetric emergencies, the mother should be taken for the cesarean delivery. So till now we discussed the main hypertensive disorders during the pregnancy, that is preeclampsia and eclampsia. The next is gestational hypertension. The sustained rise of BP to 140-90 mmHg or more, at least in two occasions, 4 or more hours apart. It can be usually seen beyond 20th week of pregnancy or during the first 24 hours after the delivery in a previously normotensive woman, that is gestational hypertension. Next type is a chronic hypertension that is usually seen before the 20th week of pregnancy, and it can extend beyond 42 days after delivery. That type is a chronic hypertension, and the main risk factors are age above 40 years, duration of hypertension more than 15 years, and the level of BP will be more than 160, 110, and the mother will have some predisposing medical disorders also. Next type is the essential hypertension. So in this condition, the BP will be more than 140/90, which can be seen prior to the 20th week of gestation. And in chest radiography, there will be the cardiac enlargement, and there will be a persistent rise of BP even after 42 days of delivery. And it can mainly affect the fetus, which can result in placental insufficiency, ayuja babies, preterm baby, perinatal loss, and there is more chance of placental abduction, that means premature removal of placenta during the pregnancy itself. In the management part, the first thing is to stabilize the BP, prevent the superimposed preeclampsia, monitor the maternal and fetal well-being, terminate the pregnancy according to the condition of mother and baby. In general management, the mother should give an adequate rest, low salt diet should be preferred. The sedatives can be given, frequent checkups for the mother, and can be started antihypertensive drugs to control the BP. In obstetric management, if there is mild case of controlled BP, the spontaneous labor can be done if the baby is in term, and continue the pregnancy to 34 to 37 weeks if it is in premature stage. The termination done by LRM plus oxytocin plus prostaglandin, seeing the condition of the mother. So in this section of hypertensive disorders in mothers during pregnancy, we have covered almost all the hypertensive disorders like preeclampsia, eclampsia, gestational hypertension, chronic hypertension, and essential hypertension. I hope you all are clear about these topics. Thank you for listening.